and to link growth plate pathology along with to calcium, phosphate, vitamin D, a parathormone, and FTF23 physiology, and use the pattern-based biochemical approach to diagnose. And further, we will discuss about the vitamin D and calcium and targeted therapy in different kinds of rickets, like burosumab in hypophosphatemic rickets. And later on, we'll discuss about the orthopedic decision making of deformity correction, guided growth, osteotomy, timings, and orthopedic related problems with rickets. So to define rickets, it is basically defined as softening or weakening of the bones in an immature or developing skeleton. It occurs due to the defective mineralization and architectural disruption of the physis and the osteoid. It basically occurs due to impaired mechanism of chondrocyte apoptosis, which occurs due to the disturbances in vitamin D metabolism and calcium and phosphate levels. So fundamentally, it is a metabolic disorder. First of all, in order to understand rickets, we need to understand the vitamin D metabolism. As we all know, it is vitamin D, primarily cholecalciferol, is synthesized in the skin, or it can be ingested in a precursor form via meals. And then in liver, it is hydroxylized. Uh, First hydroxylation takes place by 25 hydroxylase, and it is then converted to 25 hydroxy cholecalciferol. And further hydroxylation, second hydroxylation is done in kidneys by 1 alpha hydroxylase, after which it is converted into its activated form, which is 1,25 dihydroxy vitamin D cholecalciferol. That is what is the active metabolite, and that binds to the vitamin D receptors and further causing its action in the bone, muscle, intestine, and kidneys, where it increases the uptake or reabsorption or calcium and phosphorus absorption. So, bone mineralization basically has four controllers. First is calcium. An adequate ionized calcium for chondrocyte apoptosis and osteoid mineralization is required. Second is phosphate. The phosphate ion is rate limiting for hydroxyapatite. In a chronic phosphate deficit, there can be widening of the growth plate or along with osteomalacia. Vitamin D access is also very important. As we know, the 25 hydroxy vitamin D is the storage form of vitamin D, which further gets hy- hydroxylase in the kidneys, and then it forms the active form. The active form increases the intestinal calcium and phosphorus absorption, and the level of 1 to 1 and 25 dihydroxy vitamin D, it depends on the renal 1 alpha hydroxylase levels. Parathormone and fibroelastin growth factor 23, uh, both are kind of uh, work along. If the parathormone increases, it increases calcium and reduces phosphorus, whereas FGF23, it reduces phosphorus by specifically by renal waste, and therefore reducing the total vitamin D3. That is kind of the pathology in X-linked hypophosphatemia. Now, how does this affect the pathology? How does this affect the physis? So basically, if uh, any of these processes are disruptive or defective, it will cause failure of mineralization of the hypertrophic cartilage, thus causing widening and irregular physis. Metaphyseal changes occur, such as cupping, fraying, splaying. Looser zones can occur in severe diseases, and there can be a mechanical axis drift due to soft metaphyseal bone, which leads to progressive varus valgus deformity and along with torsion. So bone is soft and under load the deformity occurs, and correction requires both biological and mechanical correction. So pathophysiologically, if you see on the left hand side, we can see the uh, normal growth plate, and we can see how different zones of normal growth plate. But in a rachitic growth plate, there is disordered vascular invasion. Zone of provisional calcification is not mineralized, and there is accumulation of soft osteoid, therefore causing a radiological appearance of widened and radiolucent physeal gap. Now, to classify, we basically classify rickets into a nutritional and non-nutritional type. Nutritional is basically when there is a deficiency of any of the required elements that we previously discussed, such as vitamin D deficiency, in which there is low vitamin D storage or low vitamin D intake, or a deficiency due to any malabsorption or cholestasis, which causes deficiency of vitamin D. It could be a calcium deficiency, in which the low intake of calcium, uh, but there is a normal level of vitamin D, or it could be a combined deficiency. Also, there could be a risk factor driven deficiency, such as prematurity or malabsorption or cholestasis, as I mentioned earlier. If the rickets is atypical or non-responsive to vitamin D treatment, then we think about non-nutritional rickets. Uh, Following are the non-nutritional types: FGF-mediated hypophosphatemia, amongst which X-linked hypophosphatemia, autosomal dominant hypophosphatemic rickets, and TIO, which is tumor-induced osteomalacia. Non-FGF 23 hypophosphatemia, amongst which Fanconi syndrome and HHRH, which is hereditary hypophosphatemic rickets with hypercalciuria. There are some types of vitamin D dependent rickets. There are different types of it, which we'll discuss further. And then there comes the rickets, which occurs due to renal rickets or renal pathology or chronic kidney disease, in which there is phosphate retention and secondary hyperparathyroidism. Clinical presentation of rickets. Rickets shows sign from head to toe. So first of all, starting basically a patient comes to us with deformities, typically deformities of the lower limbs or widened physis of the wrist or ankle. There could be bow legs or knock knees, depending on the stage of growth of the patient. Uh, if it's a non-weight bearing or early infant phase of patient, then they also present with craniotabes, which is a ping pong ball sensation of the skull, or frontal bossing. There can be a delayed fontanelle closure, and sometimes in X-linked hypophosphatemic rickets, there can also be a craniosynostosis. In chest, there is a rachitic rosary, which is a costochondral junction swelling, and we can also see Harrison's sulcus, which is basically the diaphragm pulling onto the ribs, which have become soft or weak due to the rachitic process. And as we said earlier, uh, lower limbs, wrist swelling or ankle swelling, and deformities of the lower limbs. Some non-osseous signs like hypocalcemic seizures or dilated cardiomyopathy, which are basically due to hypocalcemia, can also occur. But these are very severe signs, and it occurs in when there is systemic involvement as well. So these clinical features can be common in all types of rickets. These alone, it's not possible to differentiate uh, by just features which type of rickets it is. So we follow a diagnostic approach in which we confirm active rickets by seeing the clinical signs that we discussed further previously. And clinical signs, along with in long-standing cases, there could be growth failure, in which we take out X-ray wrist and knees, and there would be metaphyseal cell changes, cupping, flaying, splaying, and fraying, or there could be some looser zones. And alkaline phosphatase would be elevated in most of the cases because of the high bone metabolism. After that, we do further labs. Calcium, phosphorus, alkaline phosphatase has to be done, parathormone, and vitamin D levels. Sometimes we also look for urine markers, creatinine, urine phosphorus, and uh, so according to that, we decide or we form an algorithm in which whatever suits best, we treat the patient accordingly by diagnosing. If there is a low vitamin D and low calcium, we can conclude safely that it's a nutritional vitamin D deficiency, and we further treat it accordingly. If there is a low calcium and high PTH, that also signifies a calcium deficiency. There can be normal vitamin D or low vitamin D. If there is a low phosphorus with renal wasting, we need to calculate the tubular reabsorption rate of the phosphorus, or total tubular reabsorption of phosphorus, and glomerular filtration rate ratio. These are the markers for low phosphorus if there is a renal phosphorus wasting. And FGF23 mediated pattern, in such patients, we suspect X-linked hypophosphatemic rickets or autosomal dominant hypophosphatemic rickets. In that case, genetic testing is very helpful. And there is also a type of chronic kidney diseases or tubular diseases, and it should be managed as renal rickets. If there is a not res if it is not responsive to treatment for 6 to 12 weeks, then we should be reassessing the diagnosis and checking with the compliance as well, compliance of the therapy. We'll dive in further into the nutritional types of rickets. Why does it occur even in today's era? So basic reasons, causes of it can be maternal deficiency, which causes low neonatal stores, and mothers being unaware, as we've seen, do exclusive breastfeeding without supplementation. Dark-skinned individuals with low UVB exposure are at a higher risk for rickets. Uh, these days, indoor lifestyles and bad air pollution, covered clothing, all these things can be risk factors for nutritional rickets. Also, there is low dietary calcium in weaning diets, and a lot of places there is phytate-rich staples and limited availability of limited fortified foods. Prematurity is a major risk factor because there are low mineral storages, and malabsorption and cholestasis also can be responsible for low availability of vitamin D. Anticonvulsants cause higher excretion of vitamin D, thus causing a deficit in vitamin D, and so does chronic illnesses. So, levels of vitamin D, basically what it is, 25 hydroxy cholecalciferol is basically a storage form of this vitamin D, and that tests the deficiency best. So, but dihydroxy 125 dihydroxy vitamin D is an active metabolite, which may be normal or high in early stages, but still it cannot act as a screening test. Parathormone is a functional calcium deficit calculator basically, and there can be which causes secondary hyper PTH, and it may lag behind correction. Alkaline phosphatase is marker of osteoblast activity, and often it's marked highly in cases of rickets. And it can also be high in growth spurts, so it's not a very definitive marker. Now, deficiency rickets, it's usually under-recognized and seen where calcium intake is chronically low, such as weaning diets or limited fortification. In this kind of rickets, the vitamin D may be normal, but PTH is typically high, which causes phosphaturia and hypophosphatemia. It should be treated with adequate elemental calcium along with vitamin D. So severe deformity with relatively preserved vitamin D can be a clue to calcium deficiency rickets. So this is the typical biochemical pattern that we see. In vitamin D deficiency, there is definitely low calcium, low phosphate. There is increased alkaline phosphatase in all active rickets. And if there is hypocalcemia, you can be sure that hyper PTH is going to be there. In cases of calcium deficiency rickets, again, hyper PTH is going to be there, and due to that, it will cause hypophosphatemia, and along with that, alkaline phosphate is going to be raised. Combined deficiency, calcium and vitamin D both are going to be reduced, along with low phosphate and increased PTH. In healing phases, the calcium comes back to normal, and the alkaline phosphatase is the typical sign of healing rickets biochemically is alkaline phosphatase and on a decreasing trend, and so is PTH. So basically, we ask for AP wrist and knee X-rays in which we can see metaphyseal changes, fraying, cupping, splaying, widening of physis, and we look for looser zones and fractures if bone pain and delayed walking is there. This is an example of a rachitic X-ray, and you can see there is widening of metaphysis, and you can see splaying and metaphyseal widening as well. And such X-ray can be seen on the wrist as well, which causes the widening of the wrist. Now, the treatment part, we usually always co-prescribe calcium and vitamin D for, in order to prevent the hungry bone disease. And daily or weekly regimens are preferred for adherence. STOS regimen, which we'll discuss further, has niche use, but it needs regular monitoring. And this should be reassessed clinically and radiologically and biochemically in 6 to 12 weeks. Below the age of 1 year, vitamin D can be given at 2000 international units per day for 6 to 12 weeks, or its weekly equivalent. Calcium at the same time should be given at 30 to 75 milligram per kg per day. At 1 to 12 years of age, the dietary requirement of rickets and vitamin D3 should be given at 6,000 international units per day for 6 to 12 weeks, and 500 to 1,000 milligram per day of calcium, elemental calcium, should be given. Above the age of 12 years, 6,000 international units for 6 to 12 weeks per day, and 1,000 units, 1,000 milligrams to 1,500 milligrams per day of elemental calcium. After giving 6 to 12 weeks of therapy, we need to give a maintenance dose of 400 to 600 international units of vitamin D every day. Uh, as we discussed the standard dosing, the STOS therapy, it is advised there are three types of regimen available. One is where we can administer 6 lakh international units of vitamin D orally in 6 doses, and in 6 doses every 2 hours over a 12-hour period, followed by a daily vitamin D3 supplementation of 400 international units per day for 3 months. Other way is just a single dose of vitamin D of 3 lakhs units, single dose orally, followed by a daily dose. Or another way is 6 lakh international units intramuscularly as a single dose than 400 international unit per day. This is the STOS regime. Now we come to prevention guidelines of nutritional rickets. Endocrine Society guidelines, it suggests empirical vitamin D supplementation for age of 1 to 18 years to prevent nutritional rickets. And in infants, 400 international units per day remains the global consensus to prevent rickets. There is high risk cases of such as prematurity, dark-skinned individuals, and places where there is minimal sun exposure or malabsorption syndromes in which higher maintenance dose is to be administered. Also, a public health POV where food fortification and antenatal supplementation and infant supplementation programs are advised to be initiated. So as we discussed, all these factors, universal supplementation of infant, dietary modification and fortification in staple foods of calcium and vitamin D3, and antenatally vitamin D3 administration will lead to a reduction or eradication of the nutritional rickets. Monitoring is required because biochemical response occurs and phosphate can rise very early, and PTH also falls, and simultaneously alkaline phosphatase also declines slowly. And there will be radiological healing in case of nutritional rickets. And there is a reappearance of provisional calcification zone, which can be seen as the white line on the X-ray. And metaphyseal remodeling takes place, so a reduction of size of the physis of the broadened physis occurs. But it should be remembered to see for hypercalcemia or hypercalciuria in case of excess dosing, and because nephrocalcinosis can also occur in special groups such as hypophosphatemic rickets. And also there can be non-responsive cases, in which case we should reconsider whether the patient is compliant to our regimen or not, or if the diagnosis is wrong, or malabsorption could be there, and there could be an ongoing calcium deficiency, or it could be a renal tubular type. Now, coming to non-nutritional rickets. So, when do we think of non-nutritional rickets as an orthopedic surgeon? When the in the blood markers, vitamin D levels is normal, but there is severe rickets, or it can be at early onset, which is less than 1 year old, or there is strong familial history. There can be a disproportionate hypophosphatemia, or there can be high renal phosphate wasting. Features such as nephrocalcinosis, polyuria, glycosuria, proteinuria, suggestive of tubular diseases, again point towards hypophosphatemic rickets. Features such as craniosynostosis, dental abscess, anthosopathy, though anthosopathy occurs in the later stages, and hearing issues. It can be suggestive of X-linked hypophosphatemic rickets. And if at all, after 6 to 12 weeks of good vitamin D therapy, there is still failure of improvement, there is no signs of improvement. In that case, we should suspect non-nutritional rickets. And in such cases, then we should initiate a phosphate workup where we measure the fasting serum phosphate and urine phosphate and creatinine, serum creatinine and urine creatinine, both. Thus, these levels will help us calculate the total reabsorption of phosphate and ratio of the total reabsorption, maximum level of reabsorption of phosphate and the glomerular filtration rate. And basically, this ratio is preferred because it also compares with the renal function. And thus, we can quantify whether renal phosphate wasting or is occurring, or reabsorption is occurring or not. So it's a marker for renal phosphate reabsorption. If it is low and FGF23 is increased highly, then we can think of X-linked hypophosphatemic rickets or autosomal dominant hypophosphatemic rickets or tumor-induced osteomalacia. So this is basically FGF23 mediated. And non-FGF23 mediated rickets is basically hypophosphatemic rickets with hypercalciuria or Fanconi syndrome. And it can also occur in low intake of phosphates, in which the uh, FGF levels are also going to be low, uh, but uh, the reabsorption is going to be normal or high in order to maintain the and it can occur due to refeeding or malnutrition or alkalosis. Now we'll discuss some little things about X-linked hypophosphatemia. Basically, it is a loss of function of PHEX gene, which causes hyperactivity of the FGF23, which in turn causes reduced reabsorption of the renal phosphate and causing renal phosphate wasting. Now, since renal phosphate wasting occurs, it also causes 1-alpha hydroxylase inactivity, and therefore 125, which is the active form of vitamin D, it also becomes low. And rickets, uh, it basically shows the same clinical features that we discussed earlier of rickets, along with craniosynostosis and dental abscess. And in later stages, anthropathy can also occur. Biochemically, vitamin D3 can be low, but there will be very low levels of phosphate and high alkaline phosphatase. Calcium can be normal, and if calcium is normal, PTH is also going to be normal. So burosumab is a drug that has come up, and it is basically a human monoclonal antibody which acts against the FGF23. Thus, it restores the renal phosphate reabsorption and increases the vitamin D, active vitamin D. And clinical effects are proven uh, in ways that it shows improved healing scores and alkaline phosphatase is gets reduced, and growth and function is resumed slowly, gradually. And key advantages versus the conventional therapy is that it targets the primary driver rather than pushing the phosphate, and it requires structural monitoring of serum phosphorus, and uh, it should be monitored because hyperphosphatemia can also occur. Basically, we have evidence that in randomized active control trials, it shows superior healing versus conventional therapy, Burosumab. And long-term extension data, it report sustained improvements with acceptable safety profile. And outcome, uh, basically, rickets severity score improves faster and more completely. And serum phosphorus level normalizes. Growth and function also improves with burosumab. And generally, nephrocalcinosis is not worsened in burosumab usage. So it is the dose of burosumab is weight based, and it can be titrated to bring the fasting phosphate into the lower mid level range. Obviously, we have to avoid the hyperphosphatemia as well, and it has to be monitored, and timely monitoring should be done along with the deformity tracking and dental review. And it should be stopped or withhold if there is persistent hyperphosphatemia, and there can also be, since it's a monoclonal antibody, there can also be a severe reaction to it. Uh, Coming to orthopedic management of X-linked hypophosphatemic rickets, basic principle remains the same. we control the metabolic cause first before any major surgical intervention. And deformity patterns can be varied. Genu varum valgum can occur. There can be torsioning or tibial bowing. Assessment of the mechanical axis and torsional profile should be done. And then guided growth or osteotomy is planned depending on the growth. And earlier intervention with guided growth is advised. Uh, but for severe multiplanar deformities, osteotomy should also be considered. Or if the deformity or if the intervention is being taken place after growth is complete. Other FGF 23 mediated hypophosphatemic rickets, basically autosomal dominant hypophosphatemic rickets, in which uh, these are FGF cleavage resistant variants, and it can fluctuate. Tumor induced is rare in children, and it can be considered if it's late in onset and severe symptoms are seen, along with localized with functional imaging. Fibrous dysplasia or McCune-Albright syndrome, as we know, it can drive an FGF axis, which causes hypophosphatemia, and it should we should first treat the underlying disease and pathology, then followed by a phosphate strategy. Non-FGF hypophosphatemic rickets are following other types. One of them is hereditary hypophosphatemic rickets with hypercalciuria, in which renal phosphate wasting occurs, but FGF is low. So it is basically SLC34A3 gene mediated, and vitamin D is high, thus hypercalciuria is also happening. The key is to treat with phosphate and avoid calcitriol, as it can worsen the hypercalciuria. Then there's an entity called Fanconi syndrome, in which generalized proximal tubular loss is there, phosphate, glucose, amino acid, bicarbonates, uh, and thus causing metabolic acidosis, and which also contributes to bone diseases. Again, underlying cause has to be treated, and all the losses have to be replaced. And uh, as in such case, nephrocalcinosis has to be monitored as it can cause hypercalciuria. Now, coming to vitamin D dependent rickets, key differentiating factors are basically it's broadly divided into two types. Type 2 is basically receptor resistance, and type 1 is active metabolite formation is defective, and it occurs due to CYP gene uh, dysfunction. Type 1A is when 1 alpha hydroxylase is defunct, and that causes a very low active metabolite, 125 vitamin D, and low calcium as well. It has to be treated with calcitriol and calcium. 1B type of vitamin D dependent rickets occurs due to CYP2R1 gene, which is dysfunction of the 25 hydroxylase enzyme that occurs in liver. It causes low storage of vitamin D. Basically, vitamin D2 is low, and it has to be treated with high vitamin D dose and or calcipediol. Uh, Such type of rickets is suspected if it's early onset or there is severe hypocalcemia, and there is failure of standard vitamin D dosing. Genetic confirmation also helps with lifelong planning and family counseling. Deformity correction should be done only after the stabilization of all the parameters. So type 2 basically is it requires massive doses of calcitriol and calcium, and it resembles the resistant type of X-linked hypophosphatemia, and it may also require intervention. Coming to renal rickets, mechanism of renal rickets, we can see there is phosphate retention, reduced calcitriol, and secondary hyperparathyroidism. Metabolic acidosis can also be seen due to renal rickets. This causes growth failure, and sometimes there is also slippage of epiphysis. And we can commonly see fragility fractures and deformities in such cases. Uh, Basically, it has to be treated with nephrological consult and dietary on binders, and vitamin D analogs are given, calcium mimetics are given, and dialysis and transplant wherever it is appropriate as per the nephrologist consult. Orthopedic part, it has a higher risk of complication risk, and it has to be multidisciplinary planning as the bone quality is bad, wound healing can be compromised, and higher risk of infection is there. Plus, if the growth is reduced, then the correction might not take place. And coming to the genetics aspect of it, it can indications of genetic is when there is an early onset of rickets, if there is a positive family history, if there is persistent hypophosphatemia and atypical biochemical markers and non-responsive cases, is when genetical involvement should be there, in which multiple panels can be done. There are multiple defects that can occur, such as PHEX gene, FGF23, and in a vitamin D dependent rickets CYP27, or vitamin D receptor defective is there. And there can also be a tubular defect, renal tubular defect. In such cases, cranial mapping or dental history and hearing is also effective, and along with nephrocalcinosis. So multimodal treatment is required. And therapy selection depends on the category of the rickets, as we have discussed earlier, and recurrence risk has to be constant. So there are basically simplifying this complex thing. There can be three patterns to it. If type A, when there is low vitamin D stores, high parathormone, and alkaline phosphate is very high, we can uh, conclude that it could be a vitamin D deficiency rickets. If there is vitamin D which is normal, but calcium is low and parathormone is very high, uh, calcium is low to normal, parathormone is very high, and phosphate is also low, it is suggestive of calcium deficiency rickets. In cases of low phosphate and low reabsorption rate of phosphate, which suggests wasting of urinary phosphate. But vitamin D is normal and calcium is normal. It is suggestive of hypophosphatemic rickets. And if such a picture is associated with dental abscess, then X-linked hypophosphatemic rickets is likely, in which FGF23 will come positive. If there is hypercalciuria and high vitamin D, it can be hypercalciuric type of hypophosphatemic hereditary rickets. And if there is a proximal tubular defect or proximal tubular acidosis or glycosuria, it can be Fanconi syndrome. And if persistent symptoms are there despite normal vitamin D, phosphate handling has to be revisited. Coming to the relevant and most relevant part for us is the orthopedic management, in which the goal is to restore the mechanical axis and to correct the deformity. Indication of an intervention is when there is a persistent deformity and there is gait dysfunction and joint pain. And timing of any intervention, it has to be timed only after metabolic optimization has taken place, or at least initiation of the metabolic profile and treatment has taken place. In in cases where there is chances of remodeling, we try to do what can be called as a watchful waiting. We should first of all, after monitoring and after medical optimization, we should assess the growth potential. And if there is in 6 months to 12 months follow-up, if there is improvement in the clinical monitoring metric, such as intercondylar distance or intermalleolar distance, and along with that, if there is significant growth remaining, in those cases, spontaneous correction can occur. In such cases, we would prefer to do what is called as watchful waiting, or we will continue to monitor. But if there is a very minimal correction and persistence of deformity is there, plus skeletal maturity is coming closer, is approaching, or in cases of hypophosphatemic rickets in which remodeling is very slow, in such cases we would uh, prefer to do an orthopedic intervention, a surgical intervention. Now, prerequisites to surgical intervention, that vitamin D and the minerals such as calcium have to be replenished, and radiological evidence of normalization or betterment of the physis or improvement of the physis, which shows as distinct white line, and normalization of the physial width occurs. Biochemical markers such as ALP, it reduces and shows that there is reduced bone turnover. In such cases, we can, after all these processes are done and medical and metabolic optimization is done, we should proceed for surgical intervention. Now, decision for surgical intervention, we have two types of basically to correct the deformity. We have two types of modalities available. In cases where there is when physical growth is remaining and remaining growth is at least more than 2 years, we should prefer what is called as epiphysiodesis or guided growth. In cases where there is a severe deformity or the physis is closed or it is close to closure, or in cases where the growth remaining is even lesser than 1 year, in that cases we would prefer to do an acute correction. Now, first modality, guided growth or hemiepiphysiodesis. There is application of tension band plate on the convex side that gives an opportunity for the concave side to grow more as by reducing the growth on the convex side. Now, best response and best correction occurs in patients with more than 2 years of remaining growth, but there is also risk of rebound phenomena or risk of reversal of deformity. Here is a case example in which we can see there is a genovalgum on the right side, a severe genovalgum of right side with mean axis deviation of 3. And as we can see, they were lost to follow-up. And later on, when they came back to us, there was reversal of deformity. So previously, genovalgum deformity now presented with varus deformity. And subsequently, it had to be dealt with again growth modulation for the lateral physis as well. Second modality of treatment is basically a corrective osteotomy, in which it is preferred in cases of where there is a severe deformity and in patients who are skeletally mature or close to maturity. Acute realignment is done with fixation. It can be internal fixation with a plate or a nail or an external fixation. There is also a risk of peroneal palsy if the deformity is large. In that cases, we should be doing peroneal palsy, common peroneal release. But if this procedure is performed in early stages, it has shown that it has 90% risk of recurrence with X-linked hypophosphatemic rickets. Uh, here is another case in which we did a proximal tibial corrective osteotomy. Uh, Another case in which we did a multi-apical staged osteotomy. This is a case of hypophosphatemic rickets. But we did this when the patient was closer to when the deformity is very uh, large and it is difficult to manage this with guided growth. Summarizing the surgical intervention, primary indication for the two types is guided growth should be done when the physis is open and at least 2 years or more than 2 years of remaining growth is there. And corrective osteotomy should be performed with skeletal maturity in patients with skeletal maturity or severe deformity. There is low invasiveness in patients with guided growth, whereas corrective osteotomy is a major intervention. Correction speed in guided growth is gradual. It takes months to correct the deformity. But corrective osteotomy, it's acute correction. Recurrence risk is very low in guided growth, but if the corrective osteotomy is performed in early stages when the physis is active, it shows that there is 90% risk of recurrence in young patients. So patient selection is very important in such cases. Advantage of guided growth is that it preserves bone stock and it doesn't burn any bridges for us. So basically, we can perform an osteotomy later on if the deformity is not corrected completely with guided growth. The advantage with corrective osteotomy is that is it corrects the complex rotation and three-dimensional deformities can be addressed at the same time. Now, recently, key updates of Rickets. So, according to Endocrine Society 2024, empiric vitamin D supplementation is recommended for children and adolescents to prevent rickets. Uh, and there is growing evidence for usage of Burosumab, the monoclonal antibody, and it passes safety monitoring plus cohort data on nephrocalcinosis and growth, increasing emphasis on the early diagnosis uh, to look for signs as to look for craniosynostosis and genetic study should be done. And there should be a multidisciplinary move toward metabolic and deformity clinics for complex rickets. So clinical takeaways, first we need to, the first thing we do is we diagnose, distinguish the nutritional type from a resistant type and we have to optimize the patient first. Active rickets should not be operated. Normalize or at least decreasing trend of the alkaline phosphatase and radiographic appearance should be improved. Uh, then growth should be seen. If it's a growing child, then we should use guided growth as our correction of deformity. And it is very effective and it minimizes the morbidity. We can delay osteotomy as much as we can. We should delay it uh, because it should be reserved for skeletally mature patients. Take-home algorithm is first we confirm rickets by clinical signs, X-ray, and alkaline phosphatase levels. We get the core labs done. We match the patterns of the labs and diagnose the type of rickets. Then targeted workup is done, or a targeted therapy is provided uh, to treat the cause. If it's vitamin D deficiency, if it's vitamin D deficiency, or if it's calcium deficiency, or if it is phosphate wasting. So cause has to be treated first, and after the treatment of cause, with calcium support, we come to orthopedic planning and deformity correction after the metabolic control. If the deformity persists even after healing of rickets, we should assess the mechanical axis We should consider guided growth early, and osteotomy should be considered near the maturity. These are my references. Thank you.
Mm.